Hello everyone, my name is Narjess, Fellow of Molecular Imaging and Theranostics at Peter MacCallum Cancer Center. First, I would like to thank the organizing committee for giving me this opportunity to present our research work, which was done last year when I was practicing at Westmead Hospital. We compared the frequency and severity of immune reaction and FDG PET findings between the patients with recent history of AstraZeneca and Pfizer vaccination. I have nothing to disclose. The coronavirus pandemic commenced in late 2019, and by now, nearly 500 million people are diagnosed and over 6 million have died of COVID-19. To fight this dreadful pandemic, the only reasonable solution is broad vaccination coverage. As of now, the vaccination rate is more than 50% worldwide and about 85% in Australia. Although COVID vaccination has dramatically reduced the COVID-related death rate, it may provoke some adverse events. There are four major types of COVID vaccination. The main vaccines being used in Australia are AstraZeneca, which is a viral vector, and Pfizer and Moderna, which are mRNA-based vaccines. In general, viral vector vaccines can cause more severe and persistent side effects with more systemic presentations, including fever and fatigue, while the mRNA-based vaccines may pose patients to longer-term adverse events. In this presentation, our concentration is on regional nodal reaction post-vaccination. As you see in this image, the typical finding is a mild linear uptake in the deltoid muscle around the injection site with concurrent ipsilateral mild to moderately avid axillary lymphadenopathy. This feature is being called double sign and is near to 100% specific for vaccine-related changes. This is a case of malignant melanoma with an intraparotid lymph node metastasis, which you see on the left side. The patient had history of COVID vaccination recently, and here I would like to draw your attention to the triangular-shaped inflammatory uptake at the injection site. This finding is extremely helpful in recognizing vaccine-related changes. Deltoid uptake is seen in 30% of the cases. It's inflammatory in nature and secondary to trauma, and the mechanism is completely different from axillary uptake, which reflects immune response to vaccination. Certainly, these lymph nodes can be sometimes challenging to interpret. For example, you can see here a case of rectosigmoid adenocarcinoma, which was first suspected to be metastatic to the supraclavicular region. On second review, the patient had double sign and history of AstraZeneca vaccination 18 days prior to scan. The lymph node was sampled, which was reactive change. This is another patient with lymphoma in remission for surveillance assessment with unexpected finding of hypermetabolic axillary lymphadenopathy. The patient had history of Pfizer vaccination, which simulated lymphoma relapse. On the follow-up scan, the lymphadenopathy was completely resolved. Splenic and bone marrow uptake have also been reported post-vaccination, and it's been seen in symptomatic patients more frequently. This is an example of a patient with breast cancer, 7 years in remission, and recent history of AstraZeneca vaccination showing diffuse intense splenic uptake. Vaccine-associated hypermetabolic lymphadenopathy is more common after the second dose of COVID vaccine, also in patients receiving Moderna vaccine, in young population, immunocompetent patients, females, and patients with lower BMI. Patients with hematologic malignancy are less likely to develop regional nodal reaction, likely owing to anti-CD20 therapy. Now I would like to draw your attention to our study. Among 810 patients reviewed, 253 had history of COVID vaccination within the last 20 days prior to a scan. 50 patients without history of recent vaccination have been randomly selected as the control arm. For patients in the COVID vaccine group, 65 patients were excluded due to different reasons, including interfering active malignancy. Of 188 patients remained, 145 had AstraZeneca vaccination and 43 received Pfizer vaccination. We assessed the scans visually and semi-quantitatively for evidence of regional nodal reaction. As you see here in AstraZeneca group, detection rate of FTG-avid lymph node was 18% and 48% on visual and semi-quantitative assessment. These were 39 and 61% for Pfizer group respectively. On visual assessment, the incidence of regional nodal reaction was significantly higher post-Pfizer vaccination compared to AstraZeneca. As expected, vaccinated patients had significantly higher metabolic activity in the ipsilateral level 1 axillary lymph nodes, but the lymph node avidity in the other nodal stations was not different between vaccinated and control groups. The splenic and bone marrow uptake was not significantly higher in the vaccinated population either. Interestingly, symptomatic patients had extended metabolic activity beyond the level 1 axillary lymph nodes, involving other axillary levels as well as infra and supraclavicular nodal stations, but not the hilar nodes. Comparing the AstraZeneca and Pfizer groups, both intensity and extension of nodal reaction were significantly higher in the Pfizer group. However, the splenic and bone marrow uptake was not different between the two groups. As seen here, the incidence of infra and supraclavicular nodal reaction was 17% post-Pfizer and only 2% post-AstraZeneca vaccination. This is a patient with FDG-PET post-Pfizer vaccine. As you see here, the regional nodal reaction has not limited to level 1 axillary region, but extended towards the infra and supraclavicular nodes. This is another case of vaccine-related regional findings with extension of nodal reaction to the interpectoral region. An important question being raised here is that what is the expected range of SUV max in vaccine-related nodal uptake? The reported SUV max in the literature is up to 26, which is quite high. However, in our study, the maximum SUV max seen was up to 8.5, which means that we did not have any patient with intense vaccine-related nodal uptake. The uptake is usually more intense in the second week following the first dose, and it can persist until 10 weeks post-vaccination. This is one of our other cases post-Pfizer vaccination. As we observed in our study, the nodal activity is much higher post-Pfizer compared to AstraZeneca. The SUV max of axillary lymph nodes is up to 8.5 in this patient. There are some studies reported diminished uptake after 2 weeks. However, our study showed that while FTG uptake at the injection site was significantly reduced after the first week, the regional nodal reaction remained constant for 4 weeks post-vaccination. There are other studies reported persistence of nodal reaction at the 10th week post-vaccination. These are 3 patients, 1 day, 7 days and 28 days post-AstraZeneca vaccination from left to the right. As seen on the image, the deltoid uptake reduces over time. However, the ipsilateral axillary nodal uptake remains stable over the first 4 weeks post-vaccination. Given this pitfall, nuclear medicine specialists should consider the possibility of vaccine-related nodal reaction even when the vaccination has been performed over 1 month prior to the PET scan. Although ipsilateral axillary nodal reaction is the dominant feature post-vaccination, bilateral hypermetabolic lymph nodes are infrequently seen in patients with recent COVID vaccine. In our patient cohort, less than 2% of patients showed bilateral axillary nodal reaction. In conclusion, significant local and regional nodal reactions after both viral vector and mRNA COVID vaccination can be seen, and there is a tendency for regional nodal reaction to extend toward more remote nodal stations, especially in symptomatic patients. Patients receiving mRNA vaccines are more vulnerable for having nodal reaction compared to patients receiving viral vector vaccines. I would like to express my deep appreciation and gratitude to my colleagues at Westmead Hospital who contributed to this project, especially Mr. Scott Evans, our senior PET technologist, and a big thank to Dr. Farlow, the head of department, for his continuous support, and to Dr. Grunwald for his fantastic supervision of this research work. Thanks for your attention.